Morning. My name is Dr. Kevin Climaco. I am a Chief General Surgical Resident for the U.S. Army, and this is a day in my life. All right, now that we have sign up from the night team, we're gonna get our busy day started. We're gonna start off rounding on our patients. We're then going to go to morning report. Today is a little bit special. We have a special trauma training course with our medics. As a general surgery chief resident, we get to train our medics up. After that, we got some clinic, and then we have a pretty big add-on case this afternoon. We have a paraesophageal hernia repair. Team, good morning. Morning.
Morning, here you go.
All right, how'd everybody do overnight?
Everyone's doing pretty well. This is Mr. He came overnight, got a lap appy, so he's post-op day 1, doing pretty well. He's on clear liquids, has been tolerating that okay. But pain has been a bit of an issue since he got out of PACU, so we just need to work on that today, and then once he's good from a pain standpoint, he can go.
Sweet, let's make it happen. So what is a general surgeon? In my humble opinion, a general surgeon is a physician to their fullest degree. It's who the hospital calls or other docs call when they just don't know what's going on. Think at its purest form, surgery melds everything from anatomy, physiology, pathophysiology. You can't just throw those things out the window because as surgeons, we don't only operate, but we manage our own inpatients. We manage our ICU patients. We see our own clinic patients. So at the end of the day, a general surgeon is a doctor's doctor. They operate from head to toe. One day we can be doing thyroids for cancer. Another day we could be doing a debilitating hernia, and another day just biliary colic. We can be doing colon cancer surgery or cardiothoracic surgery. We could be fixing paraesophageal hernias or taking out breast cancer. So I think at the end of the day, what is a general surgeon? A general surgeon is the doctor I'd want if I was only gonna have one doctor left in the world. Raquel, good morning.
Hi, good morning, Dr. Climaco.
How's our lady here?
Doing well.
Yeah.
She's doing really well.
How about yourself? How are you doing?
Doing well, thank you.
Yeah.
Thank you.
All right, that's awesome.
Yeah.
Any issues?
No, none that we had last night. She had a very uneventful evening.
Okay.
Bowel movements are starting to form a little better.
Okay, good.
So yeah, no, other than that, I think she's ready to go.
That's what we want.
Okay.
All right, now that we're done rounding, we're done with morning report, we're gonna get started with the next phase of our day, which is doing some teaching, some trauma teaching. In the US Army, we believe that a chain is only as strong as its weakest link. Thankfully, we don't have any weak links. This morning, I'll be running some trauma lanes with our amazing medics. I'll be teaching some chest tube insertion, some needle decompression, and some ultrasound. Specifically, we're gonna do the EFAST, extended fast, and we're gonna be showing the medics that. We're gonna get started right now. All right, so once we have everything set up, you wanna start looking for your landmarks. We typically like to go in either the 4th or 5th, between the 4th and 5th rib space. You're gonna feel that. The cheat to that is the nipple line, and then you wanna go anterior axillary line. So that's the spot that you wanna hit. Obviously, if it's a trauma setting, you wanna do this as expedient as possible. If it's a tension type physiology, then you wanna do this super quick. Otherwise, if you have some time, you can have your whole setup here, which hopefully you have complete. We're gonna feel for our landmarks. I'm feeling for that rib space, 4th, 5th. You wanna go right here, you wanna go right over that rib because you have your neurovascular bundle. In a trauma setting, you wanna make your incision as big as possible because you don't wanna struggle putting the tube in. So you cut right down there. Nice generous incision. Make sure you police your sharps. So it's a lot more force than one thing. So again, you're riding that rib space and you just pop in, open it up, come back, open it up and you hear that rush of air. And really, once you have that rush of air, you've converted an emergency to an urgency. So you can do a finger sweep. You want to feel that rib below your finger, and then you feel the lung expand behind you. If you have everything set up, or if you have someone helping you out, then you can, a lot smoother to put this chest tube in. And you want to direct it apically. So use that same hole, come in, release her latch, and then you'll get some fogging. And then typically you just ride that tube up. And again, if you made your incision big enough in a trauma setting, no need to be sexy, no need to be cute. You can see that it's clearly inside the chest there. Once you're inside, you should get some fogging of the tube. If there's some fluid, you'll get some titling of that fluid. You'll connect this onto an atrium, and you can sew your tube and shoot your confirmation x-ray. We want to get our pericardial view, and you can either go subxiphoid for that or peristernal right here. So that's a good peristernal shot right here. I don't see any surrounding free fluid. If you can't get that shot, again, initially we try the subxiphoid, and a lot of the subxiphoid shot is not really you aiming down. I think that's a very common mistake. It's more you flatten your hand out and you push downward and you're trying to get under that rib. Again, this is your shot right here. And then we get both paracolic gutters. Again, this is a common issue for a lot of people new to ultrasound. They don't go posterior enough. You really want to drop your hand to the bed. And again, you want to see shot of spleen, shot of kidney right there, splenorenal space, no free fluid. I'm going to switch over, get my hepatorenal space right here. Sometimes you're always contending with these ribs. So after we do our hepatorenal shot right here, no free fluid, dodge that rib, and then finally we get that bladder shot right there, and you can fan up and down right there. Now that we're done with the teaching aspect of things, finally got into change into something more comfortable and casual, and then transition over to the clinic side of things. The team's already started clinic without me as I was teaching. You know, I think there are several things that you need to become a general surgeon, let alone an Army general surgeon. But one of the most, or I guess I should say two of the most important things, in my opinion, are one, having a strong support system, and two, having exceptional mentorship. Specifically with that mentorship, personally, I've just grown leaps and bounds, both technically, academically, and professionally. You know, you need those people to both build you up, but you also need that criticism, and you need to hear what you need to do better and how you can become better. So that's why I personally enjoy the whole teaching aspect, because it makes a big difference. So talking about clinic, let me take you to this board here, probably a little bit better. A lot of surgeons get a bad rap for not wanting to see clinic. I actually personally don't mind clinic. I think clinic has the benefit of building that rapport and relationship with your patient. Sometimes just hearing your words of comfort are enough for these patients, and also you get to book cases. I personally like to pre-chart check my patients for the following day. So for example, today, I know that we have 8 follow-up patients, we have 9 specs, we have 7 colo EGD specs, and then 2 procedures. I like to do this so that I know who to assign. Who do I need to see? Who does my junior need to see? Which one's appropriate for the med student, the off-service intern, and the medical students? So for example, for the specs, I know that these patients down here, they're ready to go. If the story fits, they're ready to go. I've reviewed their imaging, I've reviewed their labs. But for example, these patients here, like the second thyroid we're gonna see today still needs their FNA. And the third breast cancer patient that we're gonna see today still needs their Savvy Scout and lymphoscintigraphy orders. The rest of the things on this board are just for me to organize myself. So these are like some online trainings that I need to do and things that I've not done yet. These are my cases for next week. And then we also do a little bit of teaching on the side in the afternoons with our medical students. So we were just discussing some biliary pathology and what's bueno and no bueno. Schultz, do you remember that patient with this big skin graft on a couple of weeks ago, 3-4 weeks ago now?
Sure, yeah.
Thigh donor site? Looks outstanding, maybe about 97% take, no symptoms, no infectious symptoms. She's able to do activities of daily living. She's still taking it nice and easy like we told her, but I think we can start to advance her a little bit more.
Okay, sounds good. Let's go take a look.
Let's do it. All right, just got a call from the OR that they are now ready for us for our case today. It is a little bit of a unique day in that we're doing a case on our clinic day, which is not typically the case. We typically have 2 OR days and 1 scope day, but because this is an urgent case, we're able to add it on as a time space available case. You know, your emergent cases, such as gunshots, bad perforations, even appendicitis, those are things that you can typically add on. Typically on our elective days, we'll do things like hernias, gallbladders, but also things like breast cancer or thyroid cancer. I think one of the awesome things about general surgery is you're a head-to-toe surgeon, at least in the US Army. Certainly we have our subspecialists, but we're all trained to become the best surgeons that we can be, and that's going from head to toe. Or 19?
Yes.
The dream team. Corey, Juliet. So we've got a 23-year-old male with a giant paraesophageal hernia, otherwise healthy, no comorbidities. So I'll talk to anesthesia about the anesthesia plan, but we'll just plan to give him some Ancef. As far as positioning, we'll do supine, arms out. We'll put a Foley in. Normal prep is fine. As far as some specifics we'll need for this case, we'll need 112, at least 3 5s. Let's have a 54 and a 56 French bougie, just in case, in the room. Let's have a Maryland ligature and the endo stitch with a bunch of Surgidex. And that's about it. Anything I may have missed.
What do you want for closure?
So closure, we'll just use Vicryl, and then we'll do Vicryl monocryl. We'll use the M-Close device.
Any local for the field?
We'll do Marcaine, Exparel Marcaine, just 50-50 split.
So 2020, okay.
Yep,
What's your glove size?
7, 6.5.
And then other surgeons are gonna be with you?
Dr. Schultz will also be in the room.
And then your phone number?
646.
Okay.
Okay.
All set?
Yep.
Let's do it. So now that we're done with the clinic, we're gonna be doing the piece de resistance, as I like to say, for the day. We're doing our big paraesophageal hernia repair. This young gentleman, unfortunately, came in with a hemoglobin of about 3.6. He didn't know it at the time from what's called bleeding Cameron's ulcers. So our goal today is to bring his entire stomach back down into his abdomen, sew up his hiatus, and then do a Nissen fundoplication.
So this is a 76-year-old male who was involved in an MVC. He's arriving to us GCS 12, but hemodynamically normal. He has a pretty large abrasion and hematoma to the left side of his face and a positive seatbelt sign. He also has an obvious right ankle deformity.
All right, so first thing I see is this large hematoma on the left orbital region, just completely covering his eye. There's a little focus of extraaxial hemorrhage here in the left parafalcine region, some subarachnoid hemorrhage over the left anterior frontal lobe. And looking at the bones here, we got fracture the left zygomatic arch here, anterior, posterior maxillary sinus walls, lateral and inferior orbital walls. So this is a left-sided zygomatic-maxillary complex fracture.
Okay,
And,
thanks.
yeah, a little bit limited by motion here.
Well, I mean, he's on Xarelto, so that's gonna make him a big 3. So we'll call for a bed in the ICU. Thank you.
Okay, of course. Glad to help.
Dr. Perry, saving the day like usual.
Hey, Dr. Climaco, how's it going?
Oh, you know, another day, no other dollars.
Were you in a big colon case or?
Yeah, it's more paraesophageal, but there was a little bit of colon up in there, so.
Okay.
I know I told everyone it was only gonna take 2.5, 3 hours, but c'est la vie.
It's okay, man, I got you. It wasn't too bad.
What's going on with our gentleman here?
Yeah, so 76-year-old male, MVC, He has a head bleed on Xarelto, so big 3.
Okay.
And he had a seatbelt sign, but nothing on the CT, chest, abdomen, or pelvis. So he has neurosurgery consulted for the head bleeds, optho for the eye involvement, face for some facial fractures, and ortho for obvious right ankle deformity.
Jeez.
But
You did everything for me already.
with a bow.
With a bow. You know, Dr. Perry, good news, bad news, right?
What?
Bad news, obviously trauma.
Of course.
Good news, taken care of by the one and only Dr. Perry.
Oh, thanks, man. I
All right,
appreciate it.
I'm
Have
gonna
a
see
good
this
night,
guy.
okay?
All right, have a good one.
Bye. Time for sign out.
Time to head on home.
Let's do this.
Let's do it. Dr. McCarthy,
Hey, Kevin.
the man of the hour.
Ready to sign out?
Let's do it. B team, beasted out today. We've sufficiently diuresed our list, in my opinion. We're down to 7 people. The new patient that you will notice on your list is Mr. He's a paraesophageal hernia. Basically, historic 23-year-old male came in to the ED with some dyspnea. Turns out his hemoglobin was 3.6. They basically finished his whole workup, manometry, upper GI. He got an EGD, he got a colo. Turns out it was all from Cameron's ulcers. So today we got to play hero by doing his hiatal hernia repair in Nissen. There's 3 interrupted sutures in there. We did the full Nissen wrap. The only thing for him is he's got to do to void in 6 hours. He still has not met that when we evening rounded. His Lovenox is also due in 2 hours, if we could just make sure that he gets that. Otherwise, just strict NPO, and he can walk about the cabin. You know, Liv, I think a lot of people don't know what's the main difference between an Army general surgeon and a civilian general surgeon.
Absolutely. So every general surgery resident is going to get some core amount of training in pediatric surgery, vascular surgery, cardiothoracic surgery, colon surgery. I mean, there's a wide breadth of information that we have to be able to absorb. And when we graduate, we can say that we've had some experience in all of those things. As a military general surgery resident going on to be a general surgeon, we then have to apply everything that we've learned and more. We operate in the capacity of an orthopedic surgeon, pediatric surgeon, vascular surgeon, where all of those things would generally be specialized on the outside. We are actually expected to be able to do those things. In addition to that, I feel like all of the mentors that I have seen have joined the military specifically because they want to serve in some capacity. And so we have these mentors that have been there, been overseas, been deployed, and they apply that level of thinking to everything that they do. And so you don't necessarily see the uglier sides of medicine where people are kind of just there to earn a paycheck. Our mentors and my colleagues are there to serve, and it's a wonderful thing to do to be able to work with them every day. Okay, Kevin, give me some pros and cons of military general surgery.
Right, pros and cons. I would say pro, you already alluded to it. As an Army general surgeon, we're still expected to be a general surgeon in its purest form. Yes. 1 second we could be operating on a thyroid, another colorectal, and then another you have an emergency section that you have to do downrange. We're also expected to be a general physician, right? We manage our patients on the inpatient side of things, on the outpatient side of things. So for some people that's a negative, but to me I love that about.
You're well-rounded.
That's right, about Army general surgery.
Yep.
Probably one of the best things about being an Army general surgeon is the work environment, the team aspect of it, right? We're not just a team, we're really family. And we all look out for each other. I think prime mission is obviously our patient at hand, but right below that is the well-being of others too. Some cons, obviously, we don't get paid as much. You will deploy, so if you don't want to deploy, don't be an Army general surgeon. You have to keep up with your physical fitness. You have to do all the Army things that you hear about, online training, being moved around the country on a moment's notice. All those things still apply to us, even though we're surgeons.
Yeah.
So I'd say those are the pros and cons.
Military medicine is also very small in its own right. So the people that you rotated with as a medical student are going to be people that you might be deployed with one day. Or the orthopedic surgeon that was on your service when you guys were both interns may be somebody that you see overseas and that is helping fix your patient with you. And so it's the fact that it's so small, I think is also a pro, because I can, meet somebody 4 years ago that I will definitely see again.
Sure.
It could also be a con, so you can't burn any bridges.
Sure.
They will come back to haunt you.
Right, Dr. Perry, take us home here. What's some advice you would have for pre-meds and med students?
Okay, I would say prepare for the job above you. As a pre-med student, you need to start learning how you learn best so that you can prepare to move on to the med school phase. You need to figure out the best way to retain the information because it's going to come at you fast and it's going to come at you hard. I would say as an MS3, MS4, preparing for the job above you means preparing to be an intern. You're going to be going from learning flashcards and fake patients on pieces of paper, and all of a sudden that patient is going to be sitting in front of you. So if you start acting like an intern as an MS3 or MS4, you will already have overcome that physical barrier in your brain, and you will be prepared on July 1st of your intern year because you've already put yourself in that situation. The second piece of advice I would say is go into every patient interaction, every class with an open mind, because you could be very surprised as to what inspires you in terms of what specialty you choose. I thought I was going to be an OB-GYN and I decided not to go that route. But yeah, so general surgery all the way.
Yeah, I think that's awesome advice. For me, one of the best pieces of advice I've been given is that patients deserve a physician who is not only exceptionally competent, but also wants to be there, right? And that means so many things. That means that you have to be academically ready, you have to be technically expert, and you have to be compassionate. And just in that, it means that you have to work harder, but also take care of yourself, because you can't provide those things if you're not looking out for you.
Very true. Very true.
Well, there you have it, a day in the life of a U.S. Army General Surgery Chief Resident. For more information, visit goarmy.com/AMED. Also, if you have any questions or want to become a physician, military or otherwise, be sure to visit medschoolinsiders.com. One last piece of parting advice. At the end of a long day's work, there's this tendency or desire to want to do all these things. Can't do it. You can only probably do one thing. It typically starts with an S. You can sleep, socialize, study, strengthen, maybe a couple other S's. As for this general surgeon, I'm gonna sleep. See you guys.